Hello friends, welcome to Cortex YouTube channel. In this video, I will talk about a drug which is the most common cause of liver failure in US and almost to 50% 50% of the cases of liver transplantation. Okay, so that is the drug is none other than paracetamol. So today we will be discussing about paracetamol overdose and its management. Okay, before going to its management, let's look at the safe therapeutic dose. What is the safe therapeutic dose? So safe therapeutic dose is around 4 grams, less than 4 grams per 24 hours. Okay, so this is a safe therapeutic dose. So then what is the toxic dose? Toxic dose is more than 10 grams as a single dose or over 24 hours. Over 24 hours. So in children it's around 200 mg per kg, again same as a single dose or over 24 hours. So this is the toxic dose. That means toxicity will start appearing once the patient consumes more than this level of drugs. So yeah, then before going to clinical features and its management, let's look at the way of metabolism of paracetamol, how our liver handles the paracetamol when consumed. Okay, when paracetamol is taken in a lower dose or therapeutic dose, what happens to the paracetamol? In the liver, it will metabolized to variety of inactive metabolites, like it can get sulfonation, sulfotransferases, enzyme will be the sulfotransferases. So sulfate, it will form paracetamol sulfate, which is a non-toxic or inactive metabolite. It will be excreted through the kidney, excreted. Okay, then it can get glucuronidation, so by UDP glucuronide transferase, okay, UGT, to form paracetamol glucuronide. Okay, which also gets excreted, and around 5 to 10% of the paracetamol will be metabolized by CYP450 enzymes, that is to be specifically CYP2E1. So this is that enzyme which converts the paracetamol to toxic metabolite, that is NAPQI, that is N-acetylparabenzoquinine. Okay, this is NAPQI is a toxic metabolite which is produced very less amount when paracetamol is consumed in a therapeutic dose. Let's suppose if you consume 4 grams and or 5% or 10% of 4 grams is 400 milligrams. 400 milligrams will be converted to NAPQI. Okay, NAPQI is a very it will be handled. There is a way to handle this toxic metabolite also in the normal liver. So normal liver has a glutathione stores, so it will be conjugated to glutathione, and it forms mercaptopuric acid or cysteine, paracetamol cysteine and mercapturate. Okay, so paracetamol cysteine and mercapturic acid. Okay, mercapturic acid or mercapturate. So this will be again excreted without causing any damage. So the one important thing I want you to remember is this toxic metabolite, that is NAPQI. Okay, this is very, very dangerous. So if a patient consumes in a toxic dose, paracetamol in a toxic dose, so more amount of, see, these two pathways are saturated, so sulfonation and glucuronidation will be get saturated, so more paracetamol will go into this pathway, toxic pathway, resulting in more amount of NAPQI and more liver damage. Okay, so how to handle if your liver is full of glutathione, if you have a glutathione stores well, so you can handle NAPQI up to a level. Okay, in patients who are already having less glutathione stores, example malnourished patients, alcoholic patients, or chronic liver disease patients, they cannot handle the excessively produced NAPQI, okay, by default having as they have liver disease, okay. So what we have to do is, we can't prevent paracetamol getting converted to NAPQI, but we can increase the rate of conversion of toxic NAPQI to non-toxic metabolites by restoring the glutathione stores or increasing the glutathione stores by giving NAC, that is N-acetylcysteine, okay. So I already told antidote for paracetamol overdose is NAPQI, N-acetylcysteine. So this is how the paracetamol gets metabolized in the body, okay. So NAPQI is the culprit here. Next, what we have to remember is clinical features. The clinical features of the paracetamol overdose can be divided into multiple stages: stage 1, 2, 3, and 4. So stage 1 is before 24 hours, that is within 24 hours of ingestion. So what the patient will complain? Patient will be having nausea, vomiting, slight discomfort, okay, this nausea, vomiting, anorexia, like that. In second stage, that is 24 to 72 hours, that is second and third day, patient's liver getting damaged. So it will start getting damaged. So your AST, liver enzymes AST, ALT will be raised, okay. And some patients may develop our right upper quadrant pain, okay. These are the second stage features. What is the third stage features? Third stage feature starts after 3 days, and it will last for 4 days, 72 to 96 hours. So here hepatic failure, coagulopathy, metabolic acidosis, all the complications will appear in the stage 3. If some patients survives this stage 3, they go for the stage 4, that is recovery phase. Or if they don't survive this phase 3, they will deteriorate and they may die in stage 4, that is stage 4 lasts after 4 days, that is more than 96 hours. Death, recovery or death, okay. So these are the stages of paracetamol poisoning or overdose. So this is clinical features. Then what is the treatment? What are the treatment options available? So management, okay. Management, it depends upon the time of presentation, when he consumed the tablets and what time he presented to emergency department. So we have a beautiful flowchart here. Whenever patient consumes acetaminophen, it can be represented as APAP in a toxic dose. If he presents well within the 4 hours of ingestion, okay. Let's suppose patient has consumed tablets at 8 p.m. If he comes before 12 p.m, so that time what you can do is GI contamination, mainly gastric lavage. You can use charcoal, activated charcoal also. GI decontamination, okay. GI decontamination, and you have to send paracetamol levels, blood paracetamol level, okay, after 4 hours. After 4 hours of ingestion, if blood levels are available, levels available before 8 hours, then before 8 hours plot on the nomogram. I will tell about this, what is this nomogram. Plot on the nomogram. If the toxic level, if it shows toxic level, you go with N-acetylcysteine. If it is non-toxic, only supportive treatment or symptomatic treatment, okay. If paracetamol levels are not available, within 4 hours, not available within 4 hours, what you can do, you give N-acetylcysteine first dose. I will tell what is this first dose, loading dose and all. After that, when blood level comes, you plot on the Nomogram. If it is toxic, you continue the treatment. If it is not toxic, you just give supportive treatment. Okay. What if he presents between 4 hours and 24 hours? Okay, before 24 hours, so you again send paracetamol levels. Again follow this. If levels are toxic levels, you give treatment, otherwise you supportive treatment. Okay. What if the patient presents after 24 hours, or the time of ingestion is unknown? So unknown time, if it is unknown time, you go for GI decontamination. Okay, if it's unknown, and you send paracetamol level, APAP levels, and you send LFT, coagulation profile, that is especially PT, okay, RFT, and give one first dose of acetylcholine, N-acetylcysteine, first dose of N-acetylcysteine. Next, okay, if APAP levels more than 10 microgram per ml, blood levels of paracetamol is more than 10 microgram per ml, or your liver enzymes are elevated like more than 1000, then you continue N-acetylcysteine infusion to continue. Okay, if yes, if they are not elevated, no, then supportive treatment. See, you have sent these values, no, investigations. You have to see if pH is less than 7.3, okay, or prothrombin more than 100, okay, or encephalopathy or altered mental status, AMS, or creatinine more than 3.3 mg per deciliter. So you have to, these are suggestive of poor prognosis, fulminant hepatic failure patients. So you have to go for what is known as liver transplantation. Okay, so this is the beautiful flow chart telling about the time of presentation and its management of paracetamol overdose. So you follow this flow chart, it will become easy. So now we will discuss about what is this N-acetylcysteine and how to give that. Okay, N-acetylcysteine is the antidote. N-acetylcysteine, or simply called as NAC. So we follow what is known as, it can be given IV, it can be given oral. Both the routes are available, and both the routes can be used. Okay, so usually what we use is IV route because of its convenience, and if patient is having intractable vomiting and all, we cannot give oral. So in that cases you can give IV. Okay, but if the drawback of IV use is patients can develop anaphylactic reactions. 5 to 20% of patients can go for anaphylaxis to the N-acetylcysteine. In that cases, you have to you can go for oral therapy, which has associated with less anaphylactic reactions. Okay, so IV therapy is recommended. What protocol we use? It is known as 21-hour protocol. 21-hour protocol. What does it mean? So N-acetylcysteine is okay, his first loading dose is given is 150 mg per kg IV in 200 ml 5D over 1 hour. Okay, so this is 150 mg per kg in 200 ml 5D 1 hour. So 5D remains the same. Fluid of choice is 5D, 5% dextrose. It remains the same. Only its volume and duration will change, and the dose of the N-acetylcysteine change. So after 1 hour, you go for 50 mg per kg IV in 500 ml 5D over 4 hours. So this is over 4 hours. Okay, after 4 hours, what you have to do is 100 mg per kg IV in 1000 ml 5D over 16 hours. Okay, So if you calculate 16 plus 4, 20, 20 plus 1, 21 hours. So that's why it's called as 21-hour protocol. So this is IV protocol. Okay, I will give you an example. If the patient is, let's suppose, 50 kg, let's make it easy. Okay, 50 kg. So what we have to do is 150 into 50. How much it will become? So if you take it 150 into, so it comes around 7.5 grams or 7,500 grams. So 7.5 grams of N-acetylcysteine, you have to mix it with 200 ml 5D and give in 1 over. Similarly here, after that 1 hour, 2.5 grams in 500 ml NS over 4 hours. 500 ml 5D. Sorry. So after that you have to go for 5 grams in 1000 ml 5D over 16 hours. So this is the calculation, 50 kg for a 50 kg person. Okay. Next, oral regimen. Both are equally efficacious. It just depends upon the patient selection and convenience. Oral regimen, you have to give loading dose of 140 mg per kg orally. Okay. After that, 70 mg per kg every 4 hours for additional of 17 doses. So you have to follow this 140 mg oral regimen when patient is not vomiting and all. Okay, but it is 72-hour protocol. Okay, this has to be finished in 72 hours. So this is the recommended protocol of N-acetylcysteine antidote treatment for paracetamol overdose. And I would like to talk about when N-acetylcysteine cannot be given or severe anaphylaxis reaction is there, in that patient, what we have to do? We can go for extracorporeal removal. Corporeal removal of toxic metabolite. Okay, that is one thing. And one more thing I want to highlight here is what is massive paracetamol overdose. Whenever patient consumes more than 40 grams in single dose or more than 500 mg per kg dose. So whenever patient consumes this much amount of paracetamol, that is considered as massive overdose. How to manage that? Your 21-hour standard 21-hour protocol is not sufficient. In addition to 21-hour IV protocol, you have to give oral protocol also, and you have to increase the third infusion dose, third dose of N-acetylcysteine. That is, if it was 100, no, you have to make it 200 mg per kg, third dose. And this dose. In massive transfusion, you have to massive overdose, you have to make it 200 mg per kg, and or you can go for reloading after completion of IV therapy. Okay, again you have to give one more loading dose after IV completion therapy. Okay, so this is the management of paracetamol overdose. Hope you find this video useful. Okay, if you have any queries or questions, you can ask in the comment section. I will be very happy to answer them. And if you find this video useful, please share among your friends, juniors, colleagues. Okay, thank you.